Hello everyone. Today we have another subspecialty VMR, and today the topic is endocrinology. And for this, we have a special guest, namely, we have Dr. Eve Blumgarni. And before giving the mic to her, I would give you some introductory words about her persona. She is a board-certified endocrinologist at North Shore University Health Systems and the director of Thyroid, as well as the director of Endocrine Innovation and Education for the Division of Endocrinology. She is a COO and co-founder of the Illinois Medical Professionals Action Collaborative Team. And she's also the Chief Development Officer of Women in Medicine, NFP. And she received her medical degree from the NYU and completed her residency and fellowship training at the Hospital of the University of Pennsylvania. Her clinical expertise is in the diagnosis and management of thyroid dysfunction and thyroid cancer. She speaks and teaches on the role of healthcare professionals in countering misinformation using social media and traditional media outlets, and through leadership roles with impact and wins, she advocates for her patients, for women in medicine, and for her fellow healthcare workers. And I would now ask her to tell us a little bit about what she likes to do outside of medicine and why you chose actually endocrinology.
Hi, so thank you so much. I love that you introduced my persona. I'm going to start using that. I am Eve Blumgarden. You guys can call me Eve in this case discussion. And okay, so why I chose endocrinology. I really liked that it was chronic disease management of all age groups, all genders, and that it was logical. If something was up, you brought it down. If something was down, you bring it up. It all makes sense. I didn't want to be called in the middle of the night for emergencies, although that is not, we do get called, but I didn't know that. And I just really enjoy the challenging clinical cases. And what do I do outside of work? So outside of work, I am a wife and I have a mom of 2 young kids. I like to sing, and sometimes we'll post our stuff on Twitter under the Docs Who Rock hashtag. I work as integral parts of 2 different nonprofits for gender equity in medicine, as well as for advocacy and countering misinformation. And I love to play tennis, and that's about it.
Awesome. And then, as you all know, our VMR wouldn't be anything without the help of our friends, namely Madalena presenting the case, and also our amazing scriber and the person that is doing teaching, describing, I'm sorry. So I would lead the way to Madalena first. Please introduce yourself.
Sure. Hello, everyone. My name is Madalena. I also go by Maddie. I'm a medical student on a research year between my 3rd and 4th year. And Eve, I'm really just so grateful that you're taking the time and are jumping right from clinic to do this case discussion and teach us. So really thank you for being here, and I'm excited to present the case.
I'm excited to hear it.
And then I would lead the way to Rafa, who is doing the scribing.
Hi, everyone. My name is Rafael, and I'm a fresh Brazilian medical graduate applying for this season, so fingers crossed. And really happy to be here with Eve. She's an incredible educator on Twitter, and I look forward to learning from her. And maybe I'll pass the mic to Yasmin now.
Hello, everyone. I am Yasmin. I am a Mexican international medical graduate. I am currently preparing for my journey to the steps, and today I will be doing the teaching points.
Great. So if anyone doesn't have questions, I guess it's a way for Madalena to start with the case.
All right, great. So Eve, just to give you a little bit of a framework, so I'm gonna describe the case in about 3 to 4 aliquots, and then Shema will ask for your thoughts after each aliquot. And if you have any clarifying questions, I'll try to answer them. All right, so the chief concern is abdominal pain. And this is a case of a 47-year-old woman who is presenting with a 4-day history of abdominal pain. A little bit of descriptors of the abdominal pain. So she describes this pain primarily in the epigastric region, but really radiating across the entire abdomen. She rates the pain as a 10 out of 10. She described it as constant and cannot identify any exacerbating or relieving factors. On review of systems, review of systems is notable for some nausea, vomiting, and diarrhea. And I will pause there to get your initial thoughts.
So as an endocrinologist, my initial thoughts are, what are you doing in my office? This is, it seems more acute than what we usually take care of. There are certainly endocrinopathies and things that can present with abdominal pain, although 10 out of 10 is a bit unusual in clinic. Certainly, in the hospital, when we get consulted, we will see this chief complaint for a variety of disorders. DKA is the big one, which is a common trigger for an endocrine consult, let's say, and abdominal pain is part of it. Acute adrenal insufficiency, bilateral adrenal hemorrhage. If somebody we're treating for osteoporosis could have an ulcer from their osteoporosis meds. I guess you could have ovarian rupture, which really shouldn't be called to us, but could be on our list of glandular things. Yeah, those are the things that initially come to mind. Our patients call us a lot with symptoms that we often refer them elsewhere. But this one sounds curious to me. I like it.
Thanks a lot, Eve, for these amazing differentials. Especially, I loved your approach for these endocrine causes of abdominal pain, because usually, as you say, when we think of life-threatening acute abdominal pain, we go through this, we have this kind of VIPO schema, thinking of vascular, inflammatory, or perforating or obstructive lesions, but especially the adrenal causes are usually also not in my head. And when we think of these endocrine causes, is there anything, any other endocrine disease we might think of, or do you say that these are the most important ones?
No, if you give me any disease process, I could probably flip it into some sort of abdominal pain is associated, although not necessarily 10 out of 10. I mean, ectopic pregnancy, appendicitis. You could have, I guess, struma ovary, would do it. You could have, let's think, an adrenal met, a pheo, basically anything that can cause a mass in the abdomen could do it. I wouldn't say hyperthyroidism in and of itself shouldn't do it. Hyperparathyroidism, unless it's associated with severe constipation, shouldn't do it, in a setting of hypercalcemia. Pituitary issues really shouldn't do it. Acromegaly, Cushing's, you wouldn't expect this presentation to be the only thing, although certainly labs and additional details can sway you either way. But yeah, typically I wouldn't say there's not a long differential for endocrinopathies that cause acute onset abdominal pain causing 10 out of 10, discomfort.
Thanks a lot for the clear explanation. Then I guess, Madalena, you can go forward.
All right, great. It's always a great refresher to think about the endocrine causes of abdominal pain. So that was a great burning point. So a little bit more of information. So it said some positive things that came out of the review systems. The patient said that she has not had any dysuria, urinary frequency, or hematuria. She does say that she's had some lethargy that's been progressive over the past 10 days. In terms of past medical history, nothing notable except for an upper respiratory infection 2 weeks ago that has since resolved. No reported medications, no pertinent family history, and no pertinent social history or health-related behaviors, no allergies. So I will jump to the physical exam. So the temperature is 101.3. The heart rate was 160. Blood pressure 92/52. Respiratory rate 20. And she was satting 100% on 2 liters nasal cannula. And in terms of the exam, so let's see, I'll jump to the cardiovascular exam here. So the cardiovascular exam revealed tachycardia, but without murmurs, rubs, or gallops. The pulmonary exam was clear to auscultation. And the abdominal exam, the abdomen was soft, diffusely tender, but no rebound or guarding, and no flank tenderness. In terms of the neuro exam, the patient was oriented to self only, The patient was lethargic, and there were the deep tendon refluxes were 3+ bilaterally. And that is what I have for the physical exam, and we'd love to hear your thoughts.
Well, so, you know, through the lens of endocrinology, you know, I think there is a concern here for thyrotoxicosis. However, I would be very concerned about infection or sepsis first, right? You know, in terms of things that cause fever, tachycardia, and altered mental status. I'm interested in what her neck looks like and what her eyes look like. And I'm interested in your 3+ deep tendon reflexes, which, you know, from somebody who's always looking at something as a thyroid problem is seeing a thyroid problem. You know, I'm interested in the duration of her altered mental status and, you know, what preceded all of this, you know, 10 days ago or so. But yeah, if we could do a drive-by visual on her, like what do her eyes look like and what does her neck look like, that would be helpful.
Another question that I have, like that is standing in the chat, there was someone writing about also a possible adrenal insufficiency, considering the lethargy and the previous upper respiratory infection as a possible trigger. Could you comment on that?
Yes, I can. So that's a great question. I think the adrenal insufficiency, if you're having a crisis, you can absolutely develop tachycardia. You know, you may or may not have a fever, and oftentimes infection precipitates a crisis in patients who have known adrenal insufficiency or as their first presentation of Addison's, for example. I wouldn't expect to see the hyperreflexia in that situation, but certainly kind of end stage adrenal insufficiency, or, you know, in a crisis, you would see the rest of the picture could certainly be there. And I do see, you know, the infection infection can often be the trigger for any sort of endocrine crisis. So that would fit in either situation.
And another question that came to me is you were assuming first a thyroid issue. Could you elaborate on that? So what made you think of thyroid intoxication?
So I will say that's not my first thought is infection, right? I mean, it's just internal medicine things. And I would not be saying that hyperthyroidism or thyrotoxicosis is like the thing you think about with this presentation, but in the setting of ruling other things out and having the hyperreflexia, which I otherwise can't explain, you know, I think it's higher on the list when you see tachycardia, narrow pulse pressure, fever, altered mental status in a woman in their 40s. It's something to think about once you've resuscitated and ruled out other things. And I think adrenal insufficiency as well. And, you know, reflexes 2 versus 3+ is like a very hard thing to figure out. So, you know, I think it may be that they have normal reflexes and that somebody interpreted them as brisk. I mean, I guess you could have some neurologic, you know, a pituitary apoplexy and maybe see something like this as well. Although in pituitary apoplexy, I'm not sure you would have hyperreflexia, but you certainly would have normal reflexes.
Thanks a lot. So then I would give the way to Madalena again.
All right. Okay. So for this next LCOT, I'll give you some initial labs and then kind of pause to get your thoughts about what we would do next. So for the labs for the CBC was unremarkable except for a white blood cell count of 15.9. In terms of some of the other chemistries, we have a sodium of 159, a BUN of 120, a creatinine of 3.1 that was previously normal when looking back at the chart, and a corrected calcium of 12.4. And the other labs in the BMP were unremarkable. Also, we got an electrocardiogram, and I can actually share my screen to show you what that showed. All right, so this was the electrocardiogram, and you know, we can pause here to get your initial thoughts, and I can share with you what the read was of this EKG.
Okay, my initial thoughts are like, I haven't looked at an EKG in a really long time, but this looks like some sort of like fib or flutter or something, you know.
Yeah.
If I'm recalling back to my days of youth, you know, which I think is in a 47-year-old is not what you would expect to see. I would have expected normal sinus or sinus tachycardia. That's interesting.
Yeah, so spot on. So this was atrial flutter, exactly. So did you want to give, yeah, did you want to give any initial thoughts before I give a little bit more information about the hospital course?
Yeah, my initial thoughts are what's up with the calcium and what's up with the kidneys. And she's profoundly dehydrated. You know, what was her glucose normal? Probably because we didn't mention it. Yeah. So,
Yeah.
I mean, I could say the profound dehydration is definitely the most startling. The hypernatremia and the BUN and creatinine don't make a lot of sense to me from any true endocrinopathy, although her hypercalcemia may be primary or secondary to whatever's going on. If you have severe, you know, in thyroid storm, you can have hypercalcemia. In hypercalcemic crisis, you can have renal failure. Both would cause an altered mental status. And so the sodium problem is certainly exacerbating the mental status. I don't know if it's driving it or affecting it. And it's possible that whatever was going on caused her to not be able to take in any PO intake or any water. She got really dehydrated. That worsened the mental status, and she took in less water. And then with fever, that's the hypernatremia, and she's just really volume down. And that may, you know, resuscitating her volume wise may actually like correct a lot of these abnormalities and leave us with what really is left over. I'm not sure, but I think that, you know, I'm not sure that she has diabetes insipidus driving any of this. Let's put it that way with that sodium. You know, I think that's the less likely, but stranger things have happened. So we'll have to see. But I'm also interested in her PTH.
Amazing. I would also have some questions to you.
Yeah.
So especially for the workup of this patient, you said you would order PTH. And generally when you see this patient and the whole workup, so what would you do next?
Oh yeah, I would make sure that the primary medicine team was all over this or the ER. But I think number one is to, I think she needs an infectious workup and volume resuscitation, you know, and I would start that.
And another question that I have, that was regarding the hypercalcemia. So basically, when we're approaching endocrine causes of hypercalcemia, you mentioned that a thyroid storm can cause this kind of hypercalcemia. Can you explain the possible mechanism that causes it?
So hyperthyroidism in general can cause an increase in calcium in the setting of just metabolic bone turnover. So it's, you know, you see the effects of thyroid hormone on bone, and it drives an elevation in calcium. We also will often see a higher alk phos with hyperthyroidism. But you know, I wouldn't expect to see a severe hypercalcemia that is causing altered mental status. That's secondary. You know, it's usually like in the 11s, maybe 12s. And with some fluid resolves down to the normal level. You can also see like concurrent primary hyperparathyroidism and hyperthyroidism, or any sort of endocrinopathy. You don't have to have one thing if you can have two, you know. And so I think it's hard to say which is which here without the phos and with this creatinine, you know, there's a lot of confounders here. And so I think it would be important to see what happens after she gets some volume. But I think I could make a case either way going backwards, you know.
And thank you so much for the great explanation. There was also a question regarding the relationship between the deep tendon reflex and the hypercalcemia. Is there any relationship?
So in hypocalcemia, we see certain neurologic findings like a spastic sign, which is where you're tapping the facial nerve, or you can see the Fresnel, I think it's called the Fresnel sign, where you like get, you know, cramping, or with the blood pressure cup, you get cramping. This is carpal tunnel, forget that. But you do see neurologic kind of slowing. But in terms of hypercalcemia causing the 3+ reflexes, Trousseau, thank you. Wow, blanking on it. I don't know that I've seen the hyperreflexia the same way, especially not at 12. I mean, you know, if a calcium is 19, we would see pretty profound like neurologic defects, but at 12, I wouldn't expect that.
Amazing. And my last question before giving the mic to Madalena is basically about the hypernatremia. Do you have an approach on hypernatremia? Because usually we always talk about hyponatremia.
I always talk about hypernatremia. So, as endocrinologists, it's like, is it diabetes insipidus or not, right? And so, this would be as easy as a urinalysis for a spec grav to see if they have concentrated urine or not. So you can get that in the ER, and that basically a spec grav is the fast way to get a urinosum.
Awesome.
So because I can elaborate. So if you have a hypernatremia with a very dilute urine, that's inappropriate. And that implies that, ADH is not on board. And what you would imagine would be is somebody with a hypernatremia has a maximum stimulus for ADH release. So in diabetes insipidus, you can have a hypernatremia with a dilute, inappropriate urine, inappropriate dilute. But typically when we see patients like this, they have incredibly concentrated urine because their ADH they're already trying to hang on to as much water as possible. They just can't, there's no water around.
Thank you so much for this clear explanation. Then Madalena, you can go forward, please.
All right, fantastic. So I'll get a little bit of information about the hospital course. So you had mentioned kind of wanting food resuscitation and kind of an concern for infection. So the patient's blood pressure, the BUN, the creatinine, and the calcium all improved with aggressive fluid resuscitation. However, the heart rate remained elevated at 150 even after the fluid resuscitation. An infectious workup was negative. And I have some more labs that I'll pause here to get your thoughts on that and kind of where you would go from there.
Yeah, so that's not surprising to see that things all got better with fluid, right? It's the ER way, for example, and it typically works. The heart rate, I guess it depends, I would say, what rhythm. And, that the answer to that probably suggests why it's either fast or slow. And then, there are, she's 47, but there are many people who, once they go into a funny rhythm, they're more likely to stay in that funny rhythm. And then there are people who have a trigger for that funny rhythm. This is like the endocrinologist view of the heart, right? So funny rhythm is technical speak, but if there's some reason that she has an arrhythmia, then it would be interesting to evaluate for that once other things have resolved. And I'd be interested to know if she's still febrile or not.
And other questions incoming from my side. So now having all these information and, putting all the information as a puzzle together, what would be your diagnosis that you think of as your first differential, and what would you do next?
Well, I still haven't heard what her neck or her eyes look like. I would be curious as to her repeat calcium level and as to whether or not you had a TSH level and a PTH.
Okay, then Madalena, you can go forward.
Yes, and I'm so sorry I don't have some of the information you asked for. So unfortunately, I don't have kind of the results of what her eyes look like, but I do have some of the thyroid studies that you asked for. So for the thyroid studies, the TSH was less than 0.01. The free T4 was 5.81, and the free T3 was 218.
And what is that? Is that high, medium, or low?
That's high.
Okay, perfect. Every range is completely different. Ours goes up to 1.6 or something, so it's just all about it. Yeah.
Get 218. Yep.
That's a free. Okay. Yeah.
Yeah. So sorry. So just to repeat. So the free T3 was 218. The free T4 was 5.81, and the TSH was less than 0.01. So very low.
Perfect. And her repeat sodium, somebody's asking in the chat, it looks like, was it normalized?
I'm sorry. I unfortunately don't have that information. I'm sorry.
Okay. So this is not a surprise, right? But she has what I would call thyrotoxicosis, like profound thyrotoxicosis, based on that TSH that's undetectable with a very high free T4. And unfortunately, the free T3, I just don't know the range. And so this, I don't know if it's really high or just high. But you know, and that can help in terms of differential to know like the magnitude of the elevation above the normal range. But this is not a little finding. This free T4 is quite high.
And
So,
now, oh, sorry.
no, go ahead.
My question was,
so obviously like the concern is like, is she in thyroid storm, right? I mean, so I think that's the right next question to ask.
The question that I have regarding this kind of thyroid storm or generally thyrotoxicosis, what are the differentials that go through your mind?
Yeah. So in the hospital, every time we see an abnormal thyroid level, we're like, just repeat it, right? Because like there's so many things that can interfere with the assay measurements, and you never want to make a full plan relying on just one set of labs in endocrinology. So we like to repeat them. Sometimes if somebody was started on a heparin drip at the same time, you can see a spurious elevation in free T4 and free T3 because actually heparin like displaces the hormone from the binding globulin, and it can be acutely elevated. And then add that to non-thyroidal illness with a low TSH, and you can have that perfect picture. I don't think that's what this is, because clinically there's suspicion, and the TSH isn't just low, it's undetectable. But I would repeat them, and I would make sure that we had some LFTs on her as well, so that we could talk about treatment options. But for her, this is somebody who, if she's, especially if she's still altered, so if she's altered and her heart rate's in the 150s, and she's this thyrotoxic, this is someone that like probably will be in the ICU for thyroid storm. And the differential for this is really not that broad. So it's either hyperthyroidism from autoimmune thyroid disease or Graves' disease, which is an endogenous process where you have an antibody telling the thyroid to work very hard, even though you have too much circulating. It's either that, or you can have a nodule that's making thyroid hormone. This is not, she's not really the right demographic for that, but it can happen certainly. And the third option is a thyroiditis, which is inflammation of the thyroid that leads to spillover of preformed thyroid hormone. And if you have a big thyroid, that can be spillover of, a couple weeks, sometimes a little longer. Typically, thyroiditis will not give you this degree of, or this severity of clinical presentation. But it could, we've seen a lot of it post-infection, and she had an upper respiratory infection, before this all started. And I would be interested to know if she had any weight loss like prior to this, and if anyone in the family had autoimmunity, and again, what she looks like. It's hard to know,
Thank you so much. There was another question in the chat regarding the patient with this probable thyroid storm, because there was no history of hypothyroidism in the past medical history. And the question is, can thyroid storm be the initial presentation of a hypothyroid state?
Mm-hmm. Yeah, for sure.
And I have also some questions regarding hyperthyroidism. So and what is the general workup in the endocrinology? Like, do you make some iodine uptake scans, or which antibodies do you determine? So what would be the further steps?
Yes, so that's a great question, and it does differ a little bit, like inpatient versus outpatient. But here, I in my clinic, if let's say somebody just walked in with these labs and I wasn't sure, there was nothing definitive on exam. Sometimes you can just tell on exam, if they have bilateral proptosis, or, really red eyes that are bulging forward. If there's diplopia, like if they have clear thyroid eye disease, that's Graves' disease. If they have a very large thyroid with a palpable thrill, which is basically like if you drape your hands along across the neck, like very lightly, you can feel almost like a baby dialysis fistula. That's what a thrill feels like. That's pretty specific for Graves'. If you have an ultrasound in the office, which I do, and you pop the ultrasound probe on, and the ultrasound shows a very a large, hyperemic, hypervascular gland without nodules, that's likely Graves'. If it shows the same thing, but there's no vascularity, that's consistent with thyroiditis. If you see one giant nodule, you're thinking more, it could be a toxic nodule, it could be a cold nodule with a background that's hot. And so I think you can get a lot of information from a physical exam and from an ultrasound. The next helpful test that I think is ranks up there is the TSI antibody, which is for thyroid stimulating immunoglobulin. It used to be known as TRAB, which is the TSH receptor antibody. But TSI antibody is more specific for stimulating antibodies or it's, for stimulating immunoglobulins, and it tells us about activity, whereas TRAB doesn't. So I would be checking the repeat studies with a TSI and ordering an ultrasound for this patient in the hospital. An iodine scan, I would not do until I had the ultrasound, because if the ultrasound gives me the answer, it's much easier than doing thyroid scintigraphy. And presumably this person who came in acutely ill has had some sort of CAT scan with contrast. And so you would have to wait, for that fully to wash out. It could take 30 days or more for the iodinated contrast to wash out.
And thank you so much for these amazing explanations. Regarding these iodine scans, what does it actually tell you? So why do you actually do it?
Yes, so I love that question. So the iodine scan, so basically the thyroid gland is the only place in the body that uses iodine. So if you radio tag the iodine and you swallow it and you have a thyroid gland that is constantly making thyroid hormone, then that tagged iodine is going to get into the cells. So think about it as like, if you have the switch is always on, then any iodine that's in the environment is going to go right through that switch, and we can take a picture and do a measurement for how much uptake. So in Graves' disease, that's going to be very high uptake at 24 hours, and the picture is going to show diffuse uptake. Whereas in a hot nodule, you're going to see all of the iodine concentrate into that nodule. So you'll see like a black circle with the surrounding is asleep. And in thyroiditis, you're going to have no uptake because the sodium iodide importer is not the issue here. The pituitary is working fine. The thyroid gland is not making thyroid hormone. It is just spilling thyroid hormone. So the body kind of knows, no, don't make more. And TSH is low. TSH typically is what drives iodine into cells. And so if you have the TSH is off in Graves' disease, but you have an antibody that looks like TSH, that's triggering the whole cascade. So, I think it is, we're just basically using the fact that the thyroid takes up iodine, and we can radio label it in order to figure out what's going on in a functional and visual level.
Thanks a lot. And another iodine question that I have is actually about, we are always told in med school, being very careful with iodine, like, when we give contrast, like, because we could trigger something like a thyrotoxicosis. But I have also read that iodine can also cause hypothyroidism. So I have to say, I still don't understand, like, it can cause both hypo and hyperthyroidism. Could you elaborate on that?
It can cause both. So there are multiple different ways that it can do that. So if you have somebody with a hot nodule or really, let's say a hot nodule where they just have a nodule with a mutation that keeps that nodule on, then if you give that person iodine, it's going to feed the fire. It's just going to be a continual source, right? So that's the first scenario. And that is what we're really talking about when we're saying that iodine can worsen a hyperthyroid state. Interestingly, if you give iodine to a Graves patient, there is a therapeutic benefit, and you can transiently shut off thyroid hormone production, but then you can escape it. So you don't want to give long-term iodine to a Graves patient, and you don't want to give any thyroid storm patient iodine without first giving them an anti-thyroid medication. And there's an order to it. In normal people or in people with underlying, let's say, Hashis, you can have the opposite, where you get like a stunning, when you get iodine overloaded, there's like a stunning and a transient like hypothyroid, like, drop in. It's basically a way to not get hyperthyroid is the mechanism. And then people who have underlying autoimmune thyroid disease like Hashis can sometimes fail to escape from that and develop hypothyroidism. So we see that with amiodarone, right, all the time. So amio has a very high iodine content. And so we see often hypothyroidism, which is the most common, but we can also see amio-induced thyrotoxicosis.
Amazing. And the last point before going to Madalena is actually, we always also hear about this Wolff-Chaikoff phenomenon. Is it basically that in these kind of iodine-induced hyperthyroidism, that this kind of escape phenomenon doesn't work, or what is it?
The Wolff-Chaikoff effect is that transient paralysis of thyroid hormone production in the setting of high doses of iodine. So the other, I mean, like, I always like look this up because we never ever use it, but I think it's like the Jod-Basedow reaction is like the iodine-induced hyperthyroidism, but you'd have to fact check me on that because it truly never comes up. But it's basically the same concepts that I just kind of review, like how iodine can trigger or paralyze, the thyroid hormone production unit.
Thank you so much for all these teaching pearls.
Somebody should fact check and see if I got those names right, but yeah.
I mean, we rarely have endocrinology VMR, and it's like,
no, I'm literally full of facts and pearls is what we do.
Thanks a lot. Then Madalena, please go ahead.
Yeah, great. Yeah, and I just definitely want to echo what Seamus said. I think you gave such a clear explanation of how thyrotoxicosis can be, an overproduction or a spillage issue, and how you use the antibodies, ultrasound, iodine uptake to distinguish those. So thank you for that teaching. So in terms of the case resolution here, so the patient, as you described, was diagnosed with a thyroid storm, and thyroid stimulating antibodies returned markedly elevated. And I'll just pause there, kind of, to see kind of what final diagnosis you would give this and how you would approach treatment.
This is my surprise face. I'm not surprised, right? So she has Graves' disease. Kudos to the lab for getting those TSI antibodies back because they can sometimes take forever. You're not going to wait for those antibodies to come back to start treatment on this patient. You would have started treatment initially, like basically right at the repeat levels. And this is somebody, because of her altered mental status, fever, hemodynamic instability, and arrhythmia, you're going to want to do the kitchen sink approach to thyroid storm until things start to improve, right? And so what does that mean? That means you're going to act to block thyroid hormone production with either PTU or methimazole. And PTU or propylthiouracil is one of my least favorite meds because it can cause fulminant hepatic failure. It has a benefit of the initial ability to block T4 to T3 conversion at certain doses or at high doses, but either, you could use that or you can start right with methimazole. Methimazole has a half-life of about 18 hours. And so you're probably going to dose it BID or TID. And because in here, the free T4 is not technically over the upper limit of normal, your dose could be about like 20 a day, but we might start higher just until things get going. And you would start that anti-thionamide medication. And then an hour later, you would give SSKI, which is iodine. You would give iodine drops. And that is to not only block production, but it's then to induce the, Wolff-Chaikoff suppression. You're also probably going to do, beta blockers, depending on her hemodynamic stability and her EF. Sometimes we don't want to give a long-acting beta blocker to somebody hemodynamically unstable who's at risk for vascular collapse. In fact, we never want to do that. And so sometimes we'll use an esmolol drip because it's fast on, fast off. If the person is hemodynamically more stable and you don't think they're in heart failure, you can certainly give something like propranolol. You have to get to pretty high doses to get that reduction in T4 to T3 conversion. But we'll often get that on board. And then you would probably give steroids to this patient as well, at least until you get a cortisol back to make sure they don't have concurrent adrenal insufficiency. And to block some of the T4 to T3 conversion, depending on how sick they were. We in endo hate steroids, so we sometimes give them, sometimes don't. And then you'd really want to see, the last thing we sometimes do is cholestyramine, which actually blocks the enterohepatic reabsorption of thyroid hormone in the GI tract. And you can see a pretty decent improvement in TFTs if you do all of those things. And then, of course, it's just supporting the patient, so making sure that hemodynamically they're stable and that their source of infection is controlled and things like that. Thyroid storm can be really scary, but if you can identify it quickly and get all of these things on board, you should do well. And if you are at the point where the patient is just completely circling the drain, you can actually do plasma exchange and get rid of the thyroid hormone and to stabilize somebody as you're waiting for the thionamides to kick in.
Thank you so much for all these explanations and teaching pearls. Regarding the Graves' disease, as mentioned, as we see these thyroid-stimulating antibodies, are these antibodies actually necessary for the diagnosis, or do you have some clinical criteria, or like I'm asking myself, could you give the diagnosis only with ultrasound and these clinical symptoms?
So you can get the diagnosis with ultrasound and with these labs and clinical findings. In particular, if the ultrasound shows a hypervascular gland, we actually call it the Graves' inferno. It's very, very specific for Graves, and it's the opposite of what you'd see on ultrasound with thyroiditis. So in the right patient with the right labs, you can use ultrasound. I do like a TSI level because I trended over time, because, moving forward into outpatient land, I'm not going to stop treatment with methimazole or with whatever we're doing. I'm not going to stop treating until their antibodies cleared so they don't recur. Now, the flip side of that is, yes, there are patients who have antibody negative Graves, and we don't have a great explanation for that. It is not common, but there are patients who are hyperthyroid with nothing else to explain it. And if you did an iodine scan, you see a very high, uptake at 24 hours, and you don't have a nodule to explain it. And so, it's not a perfect test, but it's pretty good. You can have TRAB antibodies that are not stimulating. So you can have blocking antibodies, which actually causes hypothyroidism. But the TSI tells you what you want to know in this picture. It's going to take 5 days to come back, though. And so that's where the iodine scan can sometimes be very helpful. It's faster, as you're waiting for that to come back. And if the ultrasound's equivocal or the patient's not as sick, then an iodine scan can be really helpful for thyroiditis versus Graves, while you're waiting.
Thank you so much. And another question regarding the hyperthyroidism that I have is, I have read that there are also sometimes paraneoplastic causes. I mean, you mentioned struma ovarii as a possible cause for hyperthyroidism. Is there any other kind of cancer you would think of that can cause these kind of symptoms?
So you can have thyroid cancers that are functional, like a follicular thyroid cancer will occasionally also make thyroid hormone. So especially, even like metastatic follicular cancer can do it. Sometimes primary thyroid cancers can do it. It's very unusual. The struma ovarii is really the only thing that we think of as outside of the thyroid, where the patient's thyroid tends to be normal and they just have thyroid cells in the ovary. So anytime there's a thyroid cell somewhere, that you could have. So ectopic thyroid, if you have a lingual thyroid, or, you can have a thyroglossal duct cyst that didn't fully migrate, and that can either develop, and you can get a thyroid cancer there, or you can get hyperthyroidism there as well. So anywhere along the embryologic pathway where you could have thyroid cells is the other thing. You could have, so an iodine scan might light up somewhere that you wouldn't expect. That could tell you about ectopic. But typically we typically don't see a paraneoplastic syndrome from non-thyroidal cancers or anything that's not a thyroid origin.
Another question regarding the germ cell tumors. I know that there's also chorion carcinoma, am I right? That can
yes, you are right. So that's really interesting. So you can have HCG production from chorio that is incredibly high, in the hundreds of thousands. And if you remember, HCG shares, oh gosh, I'm going to mess up the binding sites, but it's very similar to the TSH binding. And so you can induce, we see this with gestational thyrotoxicosis, but in the setting of HCG levels that are in the 100,000s, you can actually see thyroid storm. The treatment is delivery, right? Is to get rid of the tumor, but you have to make sure the patient has been prepped with, and stabilized from a thyroid standpoint first. Very good.
So much.
Very interesting.
Thank you so much for all these amazing pearls, Dr. Bloomgarden. I learned so much. And I would now lead the way to Madalena.
Yeah, so that's really the resolution of the case. You hit it spot on, and I have here that the patient was started exactly as you said on propranolol, hydrocortisone, PTU, and potassium iodide with resolution of the symptoms. And actually, a quick question I had regarding treatment for you is you kind of walked through those different medications and kind of when to use those. I'm curious about your kind of opinion on when to use radioactive ablation or even a thyroidectomy in cases like this.
Yeah, so put radioactive iodine to the side for a bit. I would say the treatment is really going to, or the decision between urgent thyroidectomy versus anti-thionamide therapy is going to be based on the patient's response. And if they're clinically able to, if they're clinically responding to medications and stabilizing, or if they're not. So somebody who's, persistent thyroid storm where you're bringing out plasma exchange, and let's say the whole thing started because they have agranulocytosis from methimazole, they can never go back on it. That's somebody that you're just trying to bridge to an urgent thyroidectomy. Somebody who also has multiple nodules, who has a thyroid cancer and Graves, that's thyroidectomy. Somebody that I see in my office all the time is somebody who wants to get pregnant in the near future where they can't be on thionamides during pregnancy because of the teratogenic effects. I may set them up for a thyroidectomy before they start trying to conceive. And I've done that. The keys there are to have access to a really good thyroid surgeon, which I'm very fortunate to have access to more than one. And so I can give that as a fair alternative. But ultimately, I try and use methimazole as the mainstay of Graves treatment. I have a strong dislike for radioactive iodine for Graves disease. And that is because it actually, it's a known thing, but it increases the risk of thyroid eye disease. And that can be 10 years, 20 years, 30 years later, where somebody has new onset, severe vision, vision threatening abnormalities from their remote history of Graves treated with radioactive iodine. So anything that causes this surge of antibodies and that persists, I'm not going to use if I can avoid it. It also takes months, so if you treat, you're looking at 3 to 4 months of hyperthyroidism that hasn't really resolved yet. You might have to do it twice. So there is a right person for it, and there's a person that's really not right for it. And it also, there's like a lot of factors that weigh into it. But somebody who's super sick is going to, I'm not going to think to radioactive iodine is a good treatment for them. It's going to be too slow.
And thank you so much for all these amazing explanations. There was one last question regarding the hyponatremia in this case. Is there any relation to the Graves' disease, or how would you explain it in that case?
Profound dehydration. That's what I would say. I don't think there's anything else to it. I think the insensible and sensible water losses without access to water in the setting of a fever and altered mental status is, we see this not just in thyroid patients, but in patients of, who just come in sick and didn't have access to water for a long time. And our elderly patients, sometimes we'll see it, somebody who's just not tolerating anything PO, that we can get up to this. I'm assuming her sodium like completely normalized after fluids. If that makes sense. Yeah, that's exactly right. The BUN creatinine also supports that. But I don't think we have any sort of pituitary stalk involvement here, I wouldn't say.
And I would say thank you so much for coming, Dr. Bloomgarden.
You're so welcome.
So delightful having you here. I really loved the discussion and also reading through the chat comments, as you have seen. So grateful having you here, that you've taken your time. And then I would lead, also big thanks to Rafa for amazing scribing, and also Yasmin for, I see so many teaching points. It looks superb. I can't wait for it. And Madalena, thank you so much for your amazing case presentation. So then
Could I ask one quick question?
Yeah. Ask.
Oh, sorry to interrupt. Apologies we didn't have kind of details about the eye exam in this case. I know that
oh my gosh, it's okay.
Oh,
okay.
No, but I wanted to have a question was kind of what would you talked a lot about kind of the Graves' eye disease, and so what would you generally expect in Graves on the eye exam, and kind of is there a like a mechanism that's like based off of the pathology of Graves that explains that? I'm just curious.
Amazing question. So you would expect bilateral proptosis, which is like the entire orbit's pushed forward. It may be symmetric or asymmetric. Patients may not be able to close their eyes fully. You would see really red and injected eyes. You may see double vision, or they may see double vision, or diplopia, and you can see a lid lag and a stare, which you'll see with any form of this. But basically, when you're kind of following their finger up when they're doing it, you'll see the white of their eye as they follow your finger down. That's a stare or a lid lag. You might see retraction. They might describe feeling like there's something in their eyes or excessive tearing. And the mechanism is actually very interesting, not fully elucidated, but it is driven by the TSI antibodies, which happen to have receptors behind the orbit on the fibroblasts there. So we see this also, that's the mechanism for Graves' dermatopathy, or dermopathy on the shins. But the eye disease, what's really interesting about it is there is a new treatment that was approved like the day before COVID started, but that we've been using now for a few years called Tepezza, that or teprotumumab, that is an IGF-1 receptor blocker. And when you co-locate the IGF-1 receptor with the TSH receptor behind the eye, you actually get reversal of some of these eye symptoms. So it's pretty cool that we have some of these things finally figured out. I would say it's not fully understood yet, but it is, we're a lot further than we used to be on this pathway of understanding it. And, the eye disease and the hyperthyroidism are two separate things.
It's so crazy to me that the receptors are back.
Like, what is it doing there? I know. I don't know what it's doing there.
What is it doing there? Yeah.
Like, how did it get there? Yeah.
That was a fantastic explanation.
I can't explain why it's there. Thank you guys so much for having me on here. This was really fun. And I'm so glad I didn't have to make my own slides. I'd rather be surprised every time. This was great.
Thank you so much. We really enjoyed so much your presence here. And I think as a great conclusion of this amazing VMR, I would lead the way to Yasmin for these amazing teaching points.
Yes, thank you. First of all, thank you for today's case, Madeleine. Amazing case. And Dr. Bloomgarden, thank you for the amazing teaching pearls. There were a lot. I hope I could write all of them correctly. So the first teaching point, we started with the endocrinology causes of abdominal pain, which could be acute adrenal insufficiency, tumor ovari, adrenal or thyroid mets, although they are very unusual. Even the hyperthyroidism can cause severe constipation and even some pancreatic tumors. Now, in this patient, the hypercalcemia led us to think about a thyroid storm. The patients can have hyperpyrexia, tachycardia, severe nausea, vomiting, although the severe agitation and anxiety were not present in this patient. It can be the initial presentation of a hyperthyroid state. Now, there was a question, and what about the calcium? Why is it high? And there is hypercalcemia in the setting of a high bone turnover, since the thyroid storm or thyrotoxicosis is a hypermetabolic state, which the elevation of thyroid hormone elevates the osteoclastic activity and therefore elevates or increases the bone resorption. Now, the next step was to determine the Pth levels to see if it was mediated by it, as well as the TSH levels. There's another pearl. Since heparin can displace the thyroxine binding globulin, we can repeat the labs to determine how to proceed. Another pearl was the hyponatremia and diluted urine. Think about diabetes insipidus. And now when we came to the results of the TSH, these undetectable levels led us to think in thyrotoxicosis that can be due to overproduction by either a thyroid gland, an ectopic source, inappropriate release of thyroid hormone, or ingestion of exogenous thyroid hormone. And also we were looking at the TSI, these antibodies that tell the thyroid gland to become more active and release excess amounts of thyroid hormone into the blood. Now, we also had some teaching pearls about the iodine scan, since it's faster. In the time you ask for a TSI, you can do this scan. And any iodine will be detected. You can see it as a diffuse uptake, especially in Graves, that it's our patient's diagnostic. And the treatment in this case, we will have to block first the thyroid hormone with PTU or methimazole, determine the use of beta blockers for the cardiac symptoms, and cholestyramine to block resorption of thyroid hormone. And a last question was the hyponatremia in this case is most likely due to severe dehydration, and we can suspect it also due to the fun creatinine ratio. These are all the teaching pearls for today. Thank you again for this amazing case. Now I'll go back to you, dear Shema.
Thank you so much for these teaching points. This was superb. And yes, Dr. Bloomgarden, do you have any final words for this amazing VMR?
I'm so impressed with you guys. Honestly, I can't even believe I said all of that, but I can't believe you recorded it. That's amazing. And you managed to pull out all of the spot on pearls. That was really great. You guys are very impressive enterprise here. I love it.
Thank you so much. We are also wishing to see you more on VMR. And I would say,
Sure.
then I say, what an amazing VMR we had. And I hope to see you all again next time. Thank
Great
you
job,
again.
guys. That was really well done. Really well done. Are we still recording? All right. Somebody send it